When people talk about how Medicare is financed, there is often a focus on the trust funds becoming insolvent. Insolvency for Medicare would mean the program would no longer be able to pay for care the way it does now. That's a worrying thought. But the risk of insolvency only applies to one part of Medicare, and even that part wouldn't collapse entirely even if it were insolvent. So let's take a step back from insolvency and take a look at the bigger picture for ways all parts of Medicare could be made more sustainable, so that Medicare continues to be a robust program for the millions of people it serves. First things first, defining the parts of Medicare. Medicare is split into three major parts, and they're all financed differently. There's Parts A, B, and D. There is a Part C as well, which is Medicare delivered by private insurance companies in the form of Medicare Advantage plans. Since Part C is a combination of Parts A and B and sometimes D, it doesn't have a separate financing structure, so in this video, we will not be explicitly talking about Part C. Back to A, B, and D. Part A is sometimes called hospital insurance and covers things like inpatient and hospice care and care in a skilled nursing facility. Part B covers more outpatient services, including physician visits and preventive services. Part D covers outpatient prescription drugs. Parts B and D are financed through general revenues and premiums paid by Medicare beneficiaries, with additional state payments going towards Part D. This means that the bulk of Medicare is funded through general revenues and beneficiary premiums. Being funded through general revenues allows Parts B and D to weather economic downturns in a way that Part A is not as equipped for. Because here's the key difference. Part A is primarily funded by a payroll tax, not general revenues or beneficiary premiums. Payroll taxes are closely tied to the state of the economy. High employment and expanding payrolls mean more money flows into the fund, but those taxes dry up when unemployment rises or payrolls contract. If you're wondering why this program's funding is so divided, you're not alone. Even the lawmakers in office at the time of Medicare's establishment had disagreements and confusion. But before going to the history of Medicare's funding, we have to first look at Social Security. Social Security was first established in 1935 with the Social Security Act, signed into law by President Franklin D. Roosevelt. The new program provided benefits to retirees based on their earnings history, financed through a dedicated payroll tax. Some lawmakers criticized this financing for being regressive, meaning it was more burdensome to low-income earners than high-income earners. 30 years later, in 1965, President Lyndon Johnson signed a bill that created Medicare Parts A and B. While lawmakers agreed that Part B should be voluntary and funded through general revenues, Part A's participation and funding was contentious. Some wanted it to follow Social Security's model of being compulsory and funded through a payroll tax, and others wanted it to be aligned with Part B's system. Despite valid concerns about the confusion of having two different funding paths, Congress ultimately decided Part A would be funded like Social Security. Again, there were many criticisms about this being a regressive structure. Despite these criticisms, the payroll tax rate for Part A was set at 0.35%, with scheduled increases for future years, and an expectation that future legislators would continue to adjust its income cap, which was matched to Social Security's cap of $6,600 at the time. The cap was adjusted several times over the next 30 years, but with the Omnibus Budget Reconciliation Act of 1993, Congress completely eliminated the cap on earnings subject to the Part A tax. This means all earned income is subject to the Part A tax, whereas Social Security taxable income is still capped at $168,600 for 2024. As for the tax rate, the 1965 statute establishing Medicare Parts A and B had included built-in increases until 1987, when they would top out at 0.80%. Congress quickly abandoned this schedule and began a series of increases to the tax rate in 1968 that eventually reached the current rate of 1.45% in 1986. That's not the only payroll tax funding healthcare, though. In 2010, passage of the Affordable Care Act added another payroll tax to the mix. The additional Medicare tax is a 0.9% tax on high earners' wages. This tax pays for some ACA provisions in Medicare and also funds other provisions like the premium tax credit. The Healthcare and Education Reconciliation Act of 2010 amended the ACA and added the net investment income tax, a 3.8% tax on investment income for households with modified adjusted gross income over $200,000 for individuals and $250,000 for couples. Although it was created under the heading of Unearned Income Medicare Contribution, its actual text does not specify that the funds from it should go towards the Part A trust fund or to Medicare generally. To recap the funding structure and its history, Social Security came first, funded by a payroll tax with an adjustable cap and rate. Medicare Part A was funded based on this model, but its taxable income cap was eliminated so that all income is subject to its tax. Medicare Parts B and D are funded based on general revenues and premiums. Got it? Great. That was the past, now let's shift towards the future. Each year, the Medicare Trustees report discusses the financial status of both the Part A and Part B trust funds and projects the Part A fund's depletion date, the estimated time that the trust fund won't be able to meet all of its financial obligations. As a reminder, because Part B is funded through general revenue, its fund doesn't have a depletion date. Part A's depletion date is based on fluctuating amounts of revenues collected and benefits paid, along with predictions about future revenues and spending. As these balances shift, so do the trust fund's assets. It's important to note that even at depletion, the fund would remain operational, with revenues from payrolls continuing to flow in and benefits continuing to be paid out, albeit at a reduced percentage. In 2023, the Medicare trustees estimated that the fund would be depleted in 2031. In 2024, they extended it to 2036, at which time Part A would be able to pay an estimated 89% of claims. Fluctuating projections, with big gains and big losses, are a common pattern for the Part A fund. For example, from 1980 through 1982, the projections went from 14 years to 10, then to 5. In another block of years, 1997's projection was only 4 years, climbing year by year to peak at 28 years in 2001. When the projected depletion dates are worrying enough, they can trigger congressional intervention. Historically, each sharp dip in the depletion dates led to a corresponding congressional action and a subsequent rise. This cycle is the more attention-grabbing part of the Medicare program because of the depletion date inherent to Part A's funding structure. Unfortunately, that means Part B's influence on Medicare spending is often ignored. Since 2016, Part B spending has outstripped Part A spending. Any policy moves that only address the Part A fund would have no impact on this larger Part B expense. And excluding the Part B trust fund from conversations about Medicare sustainability leaves taxpayers and beneficiaries on the hook for increased Part B spending. So how do we address this snowballing Part B spending as well as the solvency issues of the Part A trust fund? First, nothing is set in stone, and Medicare's structure and funding do not have to remain as they are. The amount of funding flowing into the Part A trust fund is a policy choice that was historically subject to change to fit new circumstances. Despite increasing medical spending of the circumstances of today, the tax rate for most taxpayers has been stable since 1986. The trustees estimate that a 0.35% increase in the tax rate would extend the depletion date past the 75-year window they use for their analysis. Redirecting the net investment income tax into the trust fund where it was intended to go would also reduce solvency concerns. As the bulk of Medicare's expenses shift from the Part A fund to Part B, a trend experts anticipate will continue. Hyper-focus on the Part A fund will only further disguise opportunities for meaningful cost savings, and reforms are needed. The Inflation Reduction Act of 2022 was a significant step in reducing future drug costs, especially in Part D. The Congressional Budget Office projected that the 3 key drug provisions, price negotiations, inflation rebates, and the Part D redesign, would reduce Medicare spending and the federal deficit by $129 billion from 2022 through 2031, a significant improvement. But there is more to be done, both in drug pricing and in other reforms such as curtailing Medicare Advantage overpayment, where the program may be wasting hundreds of billions or even more than $1 trillion over the next decade. Tackling all segments of Medicare in ways that center beneficiary needs and preferences will be necessary to improve the sustainability and affordability of the program for future generations.